Disabilities. My name is Caitlin Diller, and I will be the introducer for this debate. This will be an informal debate, and we will be discussing the pros and cons of this topic. We will begin the debate with Michaela, the pro summarizer, who will be supporting the use of restraints by stating three main topics. Restraints are in the best use of individuals, how restraints keep the individuals from self-harm, and how restraints keep staff and others safe. Rachel-Mae Curtis will be illustrating with three main points, along with visuals. Second, we will hear from Rachel Marks, the fielder, who will be discussing current research, and we will hear about the types of research that was found on the use of restraints and seclusions. Third, we will begin with the con side of the debate, where we will hear from Abby Waterman, who will be discussing the use of least restrictive measures, and the illustrations will be provided by Rachel-Mae Curtis. Fourth, Kelsey Kramer will speak as the researcher discussing what the researcher found on least restrictive measures. And last, we will hear from the fielder, Rachel Marks, again, who will be answering frequently asked questions and touch base on any specific points. We will begin with the pro summarizer, Michaela.
Thank you, Caitlin. As stated previously, my name is Michaela, and I will be supporting the use of restraints. The first point I will cover supporting the use of restraints is that restraints are in the best interest of the individual. I first want to state that restraints should only be used when the crisis situation occurring cannot be managed with least restrictive means. According to Mosa et al., the use of restraints should be viewed as an extraordinary event and limited to recommended indications. Restraint requires a written order by the physician, and its use should immediately be discontinued when less restrictive alternatives are feasible. Restraints are only in the best interest of the individual when all other methods of behavior modification have been attempted and proven unsuccessful. It is also important to remember that all people should not be restrained in the same manner. According to Musa et al., the type of restraint or seclusion used should be determined by the characteristics of the patient and what is in his or her best interest. Before a restraint procedure is implemented, staff should take an in-depth look at what they want to accomplish by using a restraint, and also how to eventually fade out the use of restraints from the client's care plan. There are instances where restraints are necessary, however, they should not be used without a thorough plan being in place. Mosa et al. Also stated that guidelines should be developed in every psychiatric setting dealing with and when to act and whether to administer restraint and the duration of restraint. Legal and regulatory controls need to be implemented to monitor the use of or misuse of restraints. This must be tempered by acknowledgement of the need of added resources that ensure adequate staffing and training in the appropriate use of these procedures to prevent violence. One of the most important things to remember is the dignity and autonomy of our clients should always be considered when implementing a restraint. According to Mosa et al., the basic dignity of patients who have been restrained should be protected, e.g. they should be provided with regular personal hygiene, bathroom, exercise, and nutritional and fluid breaks. Patients who are restrained should be provided with a comfortable environment that supports and maintains human dignity. The second point I will cover is the use of restraints to protect from self-harm. Occasionally, the clients we work with will engage in severe, serious, injurious behavior or self-harm. In these instances, the primary goal should be safety of the client. According to Peterson et al., physical restraint is a widely used protective procedure, often implemented for a variety of reasons, including prevention of violence, self-injurious behavior, and injury. Restraint should not be used as a punishment for bad behavior, but should be used if it is in the safety of the client or the client is at risk because of self-harm. As stated previously, restraints being used for this purpose should always be least restrictive as possible and be faded out quickly. It is also important to consider that not all self-harm needs to be or should be managed by the use of restraint. Modulation of force is a term used to describe using the least amount of force necessary to manage a client in a restraint. For example, let's say a client engages in two types of self-harm: head banging on hard surfaces with enough force to make a sound, and hand biting with minor force that does not break the skin. If the client is cleared for restraint to prevent self-harm, it would be unacceptable to put the student into a restraint to protect against hand biting behavior when it could be managed with far less intrusive procedures. Restraint would only be used if the client engaged in head banging behavior, as this is much more severe and could cause extreme harm. The final point I would like to discuss is the use of restraint to protect staff and other students from violent behavior. As stated by Howard et al., staff in intellectual disability services can experience high levels of violence, which may lead to staff burnout. Staff burnout may result in poor quality of services. Previous research has suggested that factors such as fear of violence, self-efficacy, and staff support moderate the impact of violence and burnout. Centers in which restraints can be used can give staff the ability to cope with violence as they have been trained to react to it. As stated before, there needs to be permission from physicians or parents before a restraint can be used, and it is important to use the least restrictive restraint possible to manage a situation. There will always be hair pulls, bites, punches, and many other forms of violence in our field, but modulation of force and staff training and restraint and protective procedures can be extremely important factors to help decrease burnout. Howard et al. Also states that services which are organized to manage violence may be better placed to support staff experiencing violence. Fear of violence may decrease with the exposure to violence, perhaps due to self-efficacy. Training and support for staff may increase self-efficacy, thus reducing burnout. Training staff to be responsive and to read warning signs when crisis situations arise is an extremely important tool for staff to feel prepared when violence occurs. To summarize, restraints should be used if they are in the best interest of the client. This means exhausting all other options before moving into restraint and preserving the dignity of the client while doing so. Restraint should be used in the event of self-harm as a protective procedure if there is imminent harm to the client and behavior cannot be managed with less restrictive means. Finally, restraint training and the ability to implement restraints on extremely violent clients can decrease staff burnout and increase quality of care. Thank you. I will now pass the floor to Rachel Marks, who will be discussing current research on the use of restraints in seclusion.
So sorry, I'm really confused. I thought that I was doing just questions at the end.
Yeah, I think it says that wait, what is this? Michaela is next? No, Michaela just went. So and then Rachel-Mae was doing illustrations while you were talking, and then the researcher is next.
And that's me. So I'm confused on what I'm speaking of, because what I have written down is just the summarizations of our articles, right? So am I supposed to just read those?
You could summarize like the work that Michaela mentioned to you was mainly found in X article, and I know your summaries were
they're lengthy.
Shorten your summaries even more, but yeah, just basically say where the information came from.
So I could just state. So I'll have to redo this then, because I feel like I was very confused. I was like, this makes no sense for me reading all this as I was looking at it, because there's a lot. So I will summarize it and redo it, but I'll just say that like the research came from XXX, which summarized blah 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 blah.
Okay. I put all of my points are in the outline. Literally what I just read was in the outline, and then the articles that I used are after each point, so you can just pull from there.
Yeah, and then that's what I did last time. I just I summarized your articles that week, so I have it written. But I was like, these are paragraphs that I wrote, so I'm like, I'm not gonna sit here reading them. So I'll come up and I'll summarize them and I'll send it to you guys by Tuesday, and then you can look at them.
Cool.
So I'll do that, because I was like, look, as you're reading, I'm like, makes no sense. I was like, whatever you just said is what I'm gonna read straight from the book. Okay. So I will do that. So I will summarize it and more. Same with the con, and then I will do that on just send you guys out what I'm gonna say.
Cool.
Sorry.
No. Dry run.
No, you're fine. I was literally like looking as you're reading. I'm like, this is so much for me to read. It's gonna take me 10 minutes just to cite my articles.
Yeah.
I was like, that doesn't make sense. Okay. On to the next.
Oh, whoops.
So
it's the con. It's Abby.
Yeah, okay, so we just introduce me person.
Oh, so next we will have Abigail read the cons of restrictive methods.
Okay, so my first point that I'd like to address is the official stance of the Applied Behavior Analysis International. They believe that the inappropriate or unnecessary use of seclusion, restraint, or other intrusive interventions. They do say that if there are severe behavior problems, they can be effectively treated without the use of restrictive interventions. So the second point that I'd like to make is the psychological, physical, and emotional consequences of restraints. Those are all mixed up. Okay, so they have found that are placed in restraints and often feel physical pain, anxiety, or they feel psychological distress or anger. And the staff that are involved in these often reports anxiety, sadness, and guilt for placing the children in these restraints, and they don't quite feel, oh my God, I'm so sorry. I apologize.
You're fine.
Whew. I don't like talking very much. So I'll have to get a little more of that one. The point that I would like to address is how people in worst case scenario, we'll address worst case scenario next. So in the research that I have found through Marino and Cote, in 2006, there were reports that reported that there were 45 deaths between children and adolescents that were associated with restraints in residential settings. There was another report of 38 grown adult men that had died during or after the use of physical restraints, and 7 had died from the use of mechanical restraints. Often the cause of this was asphyxia from the prone position. Staff aren't always trained well for the individuals in a prone position without a soft mat or something else that end up cutting off their air supply. Staff often aren't always trained well either, and they put an unnecessary amount of force on the person's back, which then causes the asphyxia and causes the client to lose consciousness, and the worst possible scenario is they die. In this particular study, they also found that many of the students that they researched, their behaviors did not meet the qualifications to place them in a restraint, which means that they did not have imminent danger to self or others, but the staff then put them in it anyway. So some of the other problems that restrictive measures like restraints do are they put both the staff and patient at risk for staff can pull muscles, they can break bones, children can break bones, they're still growing. Plates are very susceptible to these injuries. In between 1988 and 1998, there were 142 deaths reported in mental health settings that were connected to the use of restraints, and a disproportionate number of these deaths were young children. In 1998, the Joint Commission for Accreditation and Healthcare Certification, they reviewed 20 restraint-related deaths and found that 40% were caused by the asphyxiation, which I earlier referenced, and the remaining 60% were from strangulation or cardiac arrest or fires. In certain cases, clients do become very aggressive and harm to the environment and others around them. People often place towels or sheets over the client's heads, and that reduces their bite or bite, which also can restrict a person's airways and cause them to lose consciousness. So in another study, there were 63 cases that were reviewed, and asphyxia was the death following this cause of death following these restraints. The restraints that were applied, 57 of them were applied appropriately and accurately. Inherent risk and danger to both the patients and the staff, even if they are implemented correctly. The next point I will address is the lack of policies in the regulation of the use of restraints. The National Disability Rights Network reported that 39% of the states still have no laws and policies or guidelines that regulate the use of restraints and seclusion. 87.5% of the states and territories still allow prone restraints or other restraints that restrict a client's breathing. 45% of the states and territories require or recommend that schools notify parents or guardians when seclusion or restraints are utilized. They recommend it, but it is not required by state law. Even though you receive from the parents to implement these restraints, they're not always notified, which could cause later backlash in the legal sector. 1999 legislation passed a law that required U.S. facilities to report any deaths that were related to the use of restraints. But following this act of legislation, reported that there were 2 or more deaths per month. And the next point I will discuss is with seclusion. By Milstein and Cotton, of 102 children in psychiatric treatment settings, they found that people use seclusion the most times were times on Mondays or Wednesdays, and it was not always used as it wasn't always years. They found that the more and the less able they were to cope with any things that occurred in their environment. And that you started out a child in seclusion, it increased every time that they were put into seclusion in this particular place. The final point I want to make is the staff burnout rate. There are high levels of stress that occur and often lead to a state of burnout, which is characterized by emotional exhaustion, reduced sense of personal accomplishment, and depersonalization of the clients. So when the factors that can lead to this are a team climate that aren't supportive to each other, the administration isn't supportive to each other, the staff don't feel support from the other staff members. Some staff feel the need to be or they feel that the children need to be put in their place. So this causes undue stress on the staff members as well. The staff members aren't always taught appropriate coping strategies for this, and this is often a cause for staff members to turn to alcohol and other drugs to curb their anxiety and feelings about putting these children in restraints. And another final factor is obviously the challenging or violent behaviors that the children can have. And that ends my point. We'll move on to...
Yeah. Okay. And then I will speak on the articles and summarize some things that you had topicked on. And then it goes again back to the pro summarizer and the con summarizer. So do I ask these questions? Are you saying that all restraints are bad for the pro? And then cons says, unless that's just different order. You see what I'm looking at on the outline?
Yeah.
Hold on. I'm going to
Towards
go
the bottom, it's
finding
like
it.
9, 10, and 11.
1 second. Sorry. I think I was on a different copy.
Is anybody keeping track of the time by any chance?
That's something I was looking at on here. For some reason, I can't find anything. So we can either set up like a timer or something.
Yeah. I mean, I've got like, I think it's 19 minutes or something right now because I started it when we did that.
I figured it'd be on here, but I looked everywhere in the settings while you guys were talking. Yeah.
Figure it out.
We'll also be more time because when I talk, I'll probably talk for like, what, 4 to 5 minutes for each one. So that's another 10 minutes right there.
Okay.
So, yeah, maybe. And then I know I have to do more of the, like, this person said this. Was that too much information to, like, handle? Since we're just
No, I think
doing
it's
this.
good. And I don't think you need to say this person and that person, because when I go into mine, I can go off of that.
Okay.
And I can say she pulled this information from da 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 da.
Okay, I'll cut that out of mine too.
Yeah, same with you too, because then as the discusser, I can talk more about the article-based information.
Okay.
So I'll do an outline and I can send it to actually both of you, and then you guys can look at it, and then I can send it to the group too. But since you guys are talking about it, I can send you more information about like me summarizing things.
I updated my section in the final draft, so I'll just transfer it to this draft so that
Cool.
you have it. Sorry, I didn't realize it was in the wrong document.
No, you're fine. I didn't realize I was in the wrong document.
What are we looking at?
9, 10, and 11. So it goes back to the pro and con summarizer. Are we skipping that, or are we taking it back to you guys?
I feel like we could add it.
I didn't know like the format that we were going to use, if it was going to be back and forth. But if it's just, you know, stating whatever, then we can go from there.
Like they say one thing and they all go back to the other thing.
Some debates you have to like one person presents and then the other one argues that point and then it goes back and forth.
Right.
Is that, I think ours is informal, so we just go straight through.
Yeah. So we'll skip that part then. So then after me, it'll go right to Rachel with the questions, right?
Yeah.
Okay.
So then I will be asking questions to the team. So should the behaviors of a staff member performing the restraint be criminal?
Now, who's answering this? Are we both like, how are we going about this? Like, cause with my personal point, then yes, it would be like for con, definitely. But I don't know how this would work.
Does anyone answer it, or can the team?
I don't know.
Or do you answer it for the team? Like our team discussed and we felt like physical restraint is
if you don't have like the appropriate consent, then yes, but I don't know.
Who doesn't speak as much in it? We can have that person answer Rachel's questions then.
that'd probably be me.
If you want it. I mean, we could do it as a group. Like we could just kind of come up with an answer and then Rachel can say it, or we can have like a specific person say the answer.
Right.
What if I don't have any other doc open? What are the questions that you have?
I thought I added everyone into my the Google Doc, but I have, should the behaviors of a staff member performing the restraint be criminal? What considerations do you make when an individual needs to be restrained but has a medical diagnosis, for example, like a heart defect or a pacemaker? What is considered an extended period of time for restraint? What happens if you do not have a full consent from a parent or a guardian to restrain? Should every school have someone trained in a restraint? What type of follow-up should be in place after the restraint? Should every state have laws in place for restraints in schools and in hospitals? How do you reduce the staff burnout rate? And how do you decide if you should restrain or seclude an individual?
Okay, so I guess, I have that doc you sent. I can type up answers so that you ask, and then I kind of answer for the group, I guess.
Does anyone have any other questions, or they don't like any of those questions?
3 that we were asked to review or answer at the end from Dr. Dickey. Which I have those if nobody else does have them.
I think if we had a better idea of how much time we have left, I think we should probably figure out how many questions we do want to answer so we don't go over that time limit.
Yeah, we're at
30
25.
Okay.
So definitely the questions that our teacher sent us directly.
Yeah, probably those first, I'd say. And then we can fill in time with the extra ones.
Mm-hmm.
So do we want to have like kind of like a couple sentences written out to the questions that the fielder has made for us, so we can kind of know who wants to talk on those? And
Yeah.
want to go off the top of your heads?
Probably not a bad idea. We could just add it into that Google Doc that Rachel made, and then we can just edit it and add things as we go throughout the week.
Yeah, I like that.
And then we'll have like a final thing done.
And who wants to do what talking? Should we put it in there or?
I think, I mean, I can write some answers out, but I think for some reason it makes sense to have the pro and con talk on those.
Yeah.
Okay.
You're the one who provided the bulk of the information.
Okay.
And it should probably be just pretty short answers.
Yeah.
Right. Like a sentence.
And that's it.
Okay. So do you want us to, Michaela and I, to go in and like answer those questions, just the two of us, and then we'll go from there? Or do we all want to kind of gather together and like?
I'm fine with whatever.
Whatever's
Sounds
easier.
ideal.
Doesn't matter. I don't mind adding either, so.
Now, are the questions that you posted, the fielder questions, are the ones from the professor on there?
No.
I'll add them on there.
Okay.
Sorry. And maybe we should add them like to the top, like someone suggested.
Yeah, probably.
Yeah, I'll add them to the top. I'm in Portland in an Airbnb, so the internet's super slow.
Oh, okay.
Okay, and I think the easiest way, so one question for you, wait, are we kind of finished?
Probably.
Yeah.
Basically.
I think so.
Are we ending
Yeah.
it with Rachel? Like, are we just answering those questions and then ending it, or are we going back to Caitlin and having her like conclude?
Maybe Caitlin should conclude. It would be better, like just sound better. Like, thank you for joining us for the debate on restraints.
Right.
Are you cool with that, Caitlin?
Put it in the outline.
Your mic is muted.
Hello? Can you hear me?
Hi.
Okay, that's weird. Had to change rooms. Yeah, I'm just going to put that in the outline.
Okay. All right, I'm going to technically